The topic of lecture, behavior management in pediatric dentistry. And today we are talking about a very important challenge in pediatric dentistry, prevention of emotional stress of children and possibility for overcoming it. The foundation of pediatric dentistry is the ability to guide children through their dental experience. In the short term, this ability is a prior condition to providing for their immediate dental needs. More long-lasting beneficial effects also can result when the seed for future dental health are planted early in life. The process of leading a child through a dental appointment had for many years been termed behavior management. As you may see definition, behavior is defined as any change in the functioning of an organism. Behavioral dentistry is an interdisciplinary science which needs to be learned, practiced and reinforced in the context of clinical care and within the community oral health care delivery system. It is rather a comprehensive methodology meant to develop a relationship between the child and the pediatric dentist. It should be viewed as a sum of all efforts made to achieve patient trust, confidence, and relieve his pain and fear. The aim of behavior management is to promote the positive dental attitude. It does not mean just the behavioral necessarily to complete a given task, but include creating a long-term interest on the patient part for ongoing. To do this, the dentist must establish a relationship based on trust with the child and parents to ensure compliance with preventive regimes and allow treatment to occur. A major difference between the treatment of children and treatment of adults is the relationships. Treating adults generally involves a one-to-one relationship, that is, a dentist-patient relationship. Treating a child, however, usually relies on a one-to-two relationship among dentist, pediatric patient, and parents. This slide illustrates relationship is known as a pediatric dentistry treatment triangle. Note that the child is at the apex of the triangle and is the focus of attention of both the family and the dental team. At the same time, please remember that there is an ever-changing, dynamic relationship among the corners of the triangle: child, family, and dental team. The arrows on the line of communication remind us that communication is reciprocal. Behavior management of children in the dental practice can be achieved by two methods: non-pharmacological methods and pharmacological methods. And today we are talking about non-pharmacological behavior management strategies. First of all, we will talk about the most important factors that determine the level of anxiety and behavior of the child in dental environment. Factors influencing child behavior in dental office are divided into three subgroups: factors involving the child, factors involving the parents, and factors involving the dentist. Factors involving the child. The response of children to the dental environment are diverse and complex. Children present for treatment with differences in ages, maturity, temperament, experience, family background, culture, and oral health status. So, we should take into consideration the following factors involving the child: growth and development, medical history, past dental experience, position of the child in the family, and the socio-economic status of the child family. Growth and development. Of course, child behavior in the dental office is determined by level of child's behavior development. But please remember, the child is not a small copy of an adult. Child development involves more than physical growth and means a sequential unfolding that may involve changes in size, shape, function, structure, or skill. Dentists should consider, first of all, a child age. Child age classification are newborn from birth to 1 month, infant from 1 month to 12 months, toddlers, children from 1 year to 3 years, preschool children from 3 to 6 years, school age from 6 to 11, 12 years, and adolescents from 12 years till approximately 18 years. Each age has its own features of psychology and perception of the world, as well as how to respond to it. Normal children go through different psychological development stages as they grow up. In next 2 slides, you can see typical personality characteristics related specific chronological ages that have relevance to dentistry. These can help in our behavioral guidance strategies. For example, if dentist knows the limitations of 2 years old vocabulary, it becomes apparent that communication must occur through the sense of touch and voice modulation rather than through the spoken words. You will discuss about characteristic of different ages group on your practical classes. As children grow, improving motor function, vocabulary, flexibility, and individuality. At the same time, it should be noted that development is very individual and there is no clearly defined relation of chronological and psychological age. The next factor influencing for the child behavior, medical experience. Children who view medical experience positively are more likely to be cooperative with dentists. Children who have bad negative experiences associated with medical treatment may be more anxious about dental treatment. Pain during previous medical visits is significantly correlation with children's behavior in the dental environment. Previous surgical experiences influence behavior at the first dental visit, but this was not the case in subsequent visit. So, when taking a medical history, the dentist should include questions about previous hospital medical contact treatment and the child response to them. Dental experience. Of course, very important factor influencing for the child behavior in dental office. Children who know they have a dental problem are more likely to exhibit negative behavior at the first dental appointment. The problem may be serious as a chronic dental abscess or simple as an extrinsic staining of dentition. The pain may be moderate or intense, real or imaginary. However, there is a tendency toward negative behavior at the first dental visit when the child believes that a dental problem exists. A common cause of children's dental fears and bad behavior is a pain during previous dental visit. Because patient has a memory of infliction of pain during treatment or tooth extraction, and child perceives the dentist as a source of pain and punishment, Such consideration provides the dentist greater motivation for education the parents about visiting the dentist before any dental problem develops. Very important, next important factor influence of for child behavior, position of the child in the family. Arrangement of the children in the family offers their behavior. Children's character is shaped by many factors, of course, but position in the family is especially important because it continually reinforced throughout life. After all, childhood is a time when we form all our habits, characteristics, and personality. For example, birth order is considered by some researchers and psychologists to be one of the most powerful influence on personality along with genetics, gender, temperament, and parenting style. Where the child is the eldest, a middle, the youngest, or single child will have a powerful impact on his character. The socioeconomic status. According to last investigation, the socioeconomic status has some influence for the child behavior because the children from families with a low socioeconomic status more common have poor dental health, early gain experiences of toothache and dental emergency aid, for example, tooth extraction, often have some problem of dental fears, and of course have general behavior problem. As you remember, pediatric dentist has to deal not only with the child but also with his parents. Parents play a very important role in child psychological development, which has a profound effect on the behavior of a child. Next, factors influencing child behavior, factors involving the parents, such as parent-child relationship, maternal anxiety, attitude of parents to dentistry. The parental influence may be grouped under the following headings. First of all, overprotective parents. They take excessive care of their children. These parents do not allow their children to experience and learn to cope with the problems and anxieties of life. Overprotection may relate to the previous history of mismarriage, death of other sibling, or serious illness of the child. As a result, child is frequently very shy, fearful of new situations, and lacking self-confidence. Overindulgent parents. Here, parents give them children whatever they want without any restraint. Child manipulates his parents into satisfying all of his want and tend to act superior, bossy, and demanding. Typically, child follows the same type of behavior during dental visit and are often called spoiled child. Authoritarian parents. Here, the parents try to instill a high level of discipline in the form of physical punishment and verbal ridicule. They may compare children with older siblings and demand the same behavior. Those children will be submission and use the delaying tactics in their attempt to avoid the dental procedure. Under affectionate parents, or so-called unloving, the child is devoid of love and affection. The lack of affection and attention to their children may result in severe emotional problems. The child usually develops resentment and non-responsive to painful procedures, or might also be loud, crying easily, and aggressive, seeking the attention that is missing at home. Rejecting parents. Children face such situation when parents have unwanted child, unhappy marriage, child interfering parents' career, etc. Parent-child relationship, we are talking about that. Please remember that it's found that child behavior in dental offices are strongly related to parental styles, preferences, and demands. Failure of parents to let limits of their children's behavior is the main parental-child bringing up problem. Dentists in practice have to anticipate these types of problems and learn to deal with them. It is suggested several methods of coping with parents and children's behavior. The next factor influences of the child behavior, parental anxiety. Investigations indicate a significant correlation between mother's anxiety and child behavior at the first dental visit. High anxiety on the part of parents tend to affect their children's behavior negatively. Although it is known that children of all ages can be affected by their mother's anxieties, the effect is greatest with those who are younger than 4 years of ages. Next factor influence of the child behavior in dental environment, attitude of parents to dentistry. It's known that parents with positive dental attitude will develop the same in the child. And the last group, factors involving the dentist. The following factors are very important in the organization of children's dental receptions: appearance of dental office, personality of the dentist, dental team skill and speed, time and length of the appointment, use of flattery, praise, and reward. Appearance of the dental office. Of course, atmosphere of the dental clinic should be pleasant and attractive. The clinic environment should relax the patient and keep him until his treatment begins. It should be well equipped with toys, tape recorder, video, TV showing cartoons, aquarium, cartoon poster, for example, coloring books, and so on. Of course, try to avoid children seeing adults in pain. What can we tell about personality of the dentist? Of course, the reaction of the child is not fixed pattern, but differs from time to time and from child to another. To child should always be called, but his or her nickname, or at least using the first name. The dentist should be able to modify his approach and language with the child to match their abilities and understandings. It is extremely important that dentist learn to mask his emotional reaction toward situation and never lose his temper, as this will create a feeling of success in the mind of the child. Dentist must be calm, smile, and show friendly attitude, and may well express disapproval to unacceptable behavior without losing personal control. All conversation should be directed towards the child, and the dentist should not talk in a loud voice or shake hands very hard. What about dental skills and speed? Of course, Dental treatment should be performed in pre-planned manner to avoid loss of time. A child can endure discomfort if he knows it is late going to end. Four-handed assistant with excellent communication skills is important in the management strategies. Time and length of appointment. The duration of the appointment should not be more than half an hour, as the child tends to lose patience. Children cannot sit in one position for a long time, and their threshold of tolerance is very low. Therefore, they should not be kept in the chair for a period longer than half an hour. Children should not be given appointment during their nap time or soon after some emotional experience, for example, birth of the sibling or death of someone close. The appointment should be kept preferably in the morning time, and duration of the visit should be distributed so that there is no rush but is not bored. One of the most important rewards the child is the approval of the dentist. In praising a child, it is better to praise the behavior than individual. Tiny gifts, such tiny gold stars, toys, or stickers, if given after treatment, have a great influence on the child's behavior. They tend to make the child happy, and dentist a good and kind person in the memory of the child. Classification of the children's behavior in dental environment. Numerous systems have been developed for classifying the behavior of children in dental environment. The knowledge of these systems can assist the dentist in directing in behavior guidance approach. The most common classification is a Frankel behavior rating scale. The scale divides behavior into 4 categories, ranging from definitely positive to definitely negative. Following is description of the scale. Rating 1 or 2 minuses, or so-called definitely negative. Child refuses treatment, immature, uncontrollable, crying forcefully, and fearful. Rating 2, 1 minus, or negative. Children reluctant to accept treatment and demonstrate some evidence of negative attitude, slightly verbal, slightly excited, able to be restrained, and procedure safely completed. Rating 3, 1 plus or positive. Child accept treatment, willing to comply with the dentist with reservation, but follows the dentist direction cooperatively. Rating 4, so-called definitely positive or 2 pluses. Child has good understanding with the dentist, interested in the dental procedures, loves and enjoys the situation. So, the Frankel method of classification can be used for recording children's behavior in the dental office. Then next, the common classification, right clinical classification. Right clinical classification places children in 3 categories: cooperative children, lacking in cooperative ability, and potentially cooperative behavior. Cooperative children. Children are reasonably relaxed. They have minimal anxiety. They may be enthusiastic, laugh and enjoy the situation. They can be treated by straightforward behavior shaping approach. In contrast is the child lacking in cooperative ability. This category includes very young children, till 3 years old, with whom communication cannot be established because of their age. Another group of children who lack cooperative ability is those with specific needs, like mental or physical disability. The severity of a child condition prohibits cooperation in the usual manner. At times, special behavior guidance technology are used for these children. Although their treatment is performed, immediate positive behavioral change cannot be expected. Management best reaches through the use of sedation and general anesthesia. Potentially cooperative behavior. Potentially cooperative children have behavior problems. Include children aged 3 through 10 years and unable to express their fears and anxieties. Their behavior is essentially reflection of their inability to cope with their anxiety. Potentially cooperative patients show some specific reactions like uncontrolled to hysterical, tense cooperative, defiant, timidity, or whining behavior. This type of behavior differs, potentially cooperative behavior, differs from that of children lacking cooperative ability because these children have the capability to perform cooperatively. This is important distinction. When a child is characterized as a potentially cooperative, clinical assessment is that the child behavior can be modified. That is, child can become cooperative. Potentially cooperative children require behavior modification procedures. And now we're discussing approaches to managing children's behavior in dentistry. And we are stopping on non-pharmacological behavior strategies. Our professional goals to enhance communication, be partner of the child and parents to positive dental attitude, and improve the children's dental health. Regarding the behavior guidance strategy, I used the following terms. Behavior management is the means by which the dental team effectively performs treatment of the child and at the same time installs a positive dental attitude. And behavior shaping is that procedure which very slowly develops behavior by reinforcing successive approximations of the desired behavior until the desired behavior comes to be. There are different methods in which the behavior of the child can be modified. It is important to understand the theory behind each method and its effect in behavior modification of the child to accept dental treatment. Objectives of behavior modification. Dentists should establish effective communication with the child and parents to gain confidence of both the child and parents and the acceptance of dental treatment, to teach the child and parents the positive aspect of preventive dental care, and as a result, to provide a relaxing and comfortable environment for the dental team to work in while treating the child. Behavior management could be started even before the child actually comes for the dental treatment to the clinic. And that's why we should remember about pre-appointment behavior modification. The merit of pre-appointment behavior modifications is that it prepares the pediatric patient and eases the introduction to the dentistry. The pre-appointment experience means bringing the child to the dental office for a tour and orientation. The child meets the receptionist, dental assistant, and dentist. If this goes well, in that case, the child is informed with certain dental environment. This removes any unfavorable imaginations of the dental office and it's personal for the child. It's received a great deal of attention because the first dental visit is crucial in the formation of a child's attitude toward dentistry. Pre-appointment behavior modifications also include other methods such as watching movies, playing games about dentistry, receiving emails from the dentist office. Pre-appointment modification include parent counseling because it's a very important aspect to be considered nowadays. Before bringing the child to the dental office, you should advise the parents never to use dentistry as a punishment to the child, not to bribe the child to go to the dentist, as this will mean to the child that there must be danger ahead, not to talk about their own fears of dentistry in front of their children, and should not promise the child that the dentist will not hurt or what dentist is not going to do. It's a very common mistake of the parents. The next question, what that should be decided by the dentist, how is better? Presenting with a parent in the dental office, or we should separate child and parents. Excluding the parents from the dental room can contribute toward developing a child-positive behavior. Exceptions in case of very young, under the 4 years old, or patient with disability. Parents must be prevented during treatment, helping in supposing communication and often providing important information and interpretation. Reasons for parents' separation, advantages, disadvantages of a parental presence in dental office. The parent often repeat orders, creating annoyance for both dentist and child. The dentist is unable to use the voice control in the presence of parent because the parent may be offended. The child attention is divided between parent and the dentist. The parent injects order which become a barrier to development of understanding between the dentist and child. Also, parental presence may be limitations based on infection control or confidentiality. Parental presence is irrelevant for conscious sedation and general anesthesia. But at minimum, parent should be encouraged to participate in examination appointment if it's possible. On this slide, you can see strategies, non-pharmacological behavior strategies used in pediatric dentistry. We use the following methods: communicative management, systemic desensitization, tell, show, do, modeling, distraction, voice control, contingency management, hypnosis, and aversive conditioning. Communicative management. It is the most basic form of behavior management and is the first step in treating a child. The aim is to develop relations with patient and gain his trust. We use two types of communication, verbal and non-verbal. For verbal communication, please try to call patients by nickname or at least by the first name. Give compliments about child behavior during the treatment. Keep the patient occupied in your conversation throughout the procedure. In conversation, use questions that get an answer other than yes or no. Answer should be more complex. The language used should consist of words that express pleasures and friendship. The use of fear-promoting words should be avoided. Explain about the procedures briefly using euphemisms. Euphemisms are the substitute words which are less provoking and is essential for effective communications. You may use the following euphemisms. For example, rubber arm is a raincoat. Needle injection, mosquito bite. Dental explorer, it's like stick. Dental drill is a small brush. Radiograph is a tooth picture. Drilling, for example, removing worms from the tooth. Non-verbal communication includes warm, friendly environment and happy smiling team. Non-verbal messages can be received from the eyes or body contact. For example, placing a hand on the child's shoulder while sitting on a chair side. The next method used as a non-pharmacological strategy is a tell, show, do. Knowingly or unknowingly, most of dentists would be using this technique in treating child patients. It is a technique of behavior shaping used with both verbal and non-verbal communication, as we mentioned it before. This technique, you see, was described in 1959 years. It's a very old technique and it used till nowadays. This technique includes 3 steps. Firstly, dentist explains the procedure to the patient in easy terms, euphemisms you remember we use, and in a way appropriate for the child's and understanding, depend on child age. It's called tell. Next step, show. Dentist slowly demonstrates the procedure to the patient. And last step, continuous procedure as described before. Do. Modeling, the next method. Modeling is a simple term refers to imitation behavior by observation. It is the type of behavior modification in which young patient can learn about dental experience by looking at other children receiving treatment as a live model or by video of child undergoing treatment. This technique seen to improve the nervous behavior of the child in the dental environment and decrease in anxiety by showing a positive outcome of the required procedure. Type of models can be live models and filmed models. Live models, there are the children in the clinic who are undergoing any dental treatment. The best live models are the siblings, usually elder brother or sister. Of course, for best effect, models should be the same age, and of course, model should exhibit appropriate behavior and be praised. But as I told, can be filmed models. The models in this case is not present physically. For example, we can have posters or small movies showing the famous cartoon characters like Mickey Mouse brushing his teeth or famous movie star being friendly to a dentist and getting his treatment done. The children readily imitate this behavior. Benefits of modeling strategies: stimulation of new behavior, facilitate behavior management, extinction of fear, disinhibition of behavior avoided. Believe that modeling is the most beneficial when compared to other means for child. Next method, distraction. Distraction this approach aims to shift the patient attention from a dental setting to some other situation or from a potentially unpleasant procedure to some other action. Distraction with words such as talking while, for example, doing local anesthesia or directing the attention through audio stories, music, or cartoons, or maybe using a water air gun, as you see on that slide. This technique is useful for all patients who can verbally communicate. Next method is a voice control. Voice control is a controlled variation of voice volume, tone, or pace to influence and direct the patient behavior. For example, changing from soft to loud voice without any changes in face expression. Such technique aim to gain attention of the child, improve his compliance, as well as to establish authority. This technique can be used alone or with other methods. Voice control is not appropriate for too young children who cannot understand or with intellectual or emotional problems. Systemic desensitization. This technique helps individuals with specific fears or phobias to overcome them by repeated contacts. It is training or steps taken to reduce the sensitivity of the patient to particular and anxiety-producing stimulation or situation or object. Each situation or object is introduced progressively, starting from least stressful object to the most stressful object. Contingency management is a method where the child's behavior is changed by presenting or withdrawing a reinforce. It can be positive reinforcement if child particular behavior is encouraged by praise or by patting on his back, the possibility of same behavior being repeated increases. And negative reinforcement, withdrawing a toy from the child on performance of unfavorable behavior. Reinforcers can be of three types using in that method. Social reinforcers include positive, for example, voice modulation, facial expression, verbal praise, etc., by all the members of the dental team. Material reinforces given the children small gift after the dental treatment has been done. And activity. The child can go and play in the garden with his friend or may play on computer once his treatment has been done. Reverse conditioning. It is a behavior modifications that eliminates a child's attempt to avoid dental treatment. These techniques, which are used in management of non-cooperative children. Of course, consent from the parents is necessary before using the procedures. And aversive conditioning include two techniques, physical restraints and technique called HOME. HOME, hand over mouth exercise. It is a technique for managing unsuitable behavior that cannot be modified by straightforward technique. It is not a punishment measure, and the dentist should not express anger when using this method. The purpose of this technique is to gain attention of highly non-cooperative child so that communication can be achieved. Indications for hand over mouth exercise technique. We may use it in healthy child who is able to understand and cooperate, but who exhibit defiance or hysterical avoidance behaviors during treatment. Children over the age of 3 years who can understand simple verbal communication. So, contraindications, the technique should not be used with frightened children, and it not be used in their young age or with children who have physical or mental disability. How should we do it? Description of technique. The dentist gently but firmly places his hand over the child's mouth, and the child is told that when child cooperates, the hand will be removed. When the patient indicates his readiness to cooperate, the hand is removed and the patient is re-evaluated. Of course, the airway should never be closed during that technique. And as you remember, aversive conditioning include physical restraint. Physical restraint include partial or complete immobilization with staff, parents, or devices to protect the patient and staff from injury during dental treatment. Physical restraint can be ranged from gently holding the child's hands during the injection procedure to full body restraint. The parent must be informed that the technique is safe and effective, and their consent must be obtained. Aims of the technique: to control patient movements and prevent self-injury, to teach child that resistance is unnecessary and he is willing to cooperate. They should cause no injury to the patient and used only when necessary. Indications. It can be used for patients who are not capable of understanding the dental procedure, and for some mentally or physically handicapped patients because they have difficulty to control movements of their arms and legs. Physical restraint are divided on two types, active and passive, and as you see, they may also be divided based on area of use. For example, to control head movement, can be used special head position, you see on that slide. To control body movement, safety belt, triangular sheet, and so on. Also, you may see some examples on the slide. And To control the oral cavity can be used intraoral mouse probe and extraoral mouse probe. For intraoral controlling, we use raped tongue blades or bite blocks. For example, on the slide, you may see special bite blocks that they're often used for controlling the oral cavity situation. And about extraoral mouse probe, mold mouse probe, which is constructed of metal, you see on the slide, and covered with rubber tubing. More common is used in surgery. So, we have discussed with you about factors influence for the child behavior in dental environment, about classification of child behavior, and about strategies used for non-pharmacological management behavior control. But when you make decision about what is a strategy is better for a certain patient, please remember that choice of behavior management techniques must be based on evaluation that weighs risk versus benefits to the child. And you should take into consideration the following factors: agency of a care, alternative methods including referral, need for cooperation, skill of the dentist and dentist team, options available at each clinic, expectation of the parents and caregivers, emotional development of the child, and past medical history. In the case when behavior management techniques are not effective, we recommend to use pharmacological behavior management. Pharmacological means of behavior management should be used only when patient lack cooperative ability or systemic condition requires it. And pharmacological behavior management include conscious sedation and general anesthesia. We will talk about that on the next lecture. Thank you for your attention.